Now we're talking about what happens after the kidneys. So, micturition is the fancy term for urination. So, micturition is urinating. The ureters, again, the tubes that connect the kidneys down to the urinary bladder, are going to be lined by smooth muscle. They're hollow tubes, and it helps with peristalsis. So remember peristalsis from the digestive system, where we're trying to move things along the tube. Not only does gravity help, because the kidneys are higher than the urinary bladder, so gravity is going to help with moving urine down, but we also have smooth muscle that's going to squeeze in that specific pattern, squeeze behind it, push, squeeze a little more. So remember, if it's a tube, it'll squish here, move the fluid forward, then it'll squish here and move the fluid forward. So it has that contraction, relaxation um, pattern. And every 30 seconds, this is occurring. So we're going to go from the renal pelvis, where all of the urine is draining down to go into the ureter, towards the urinary bladder. Then in the urinary bladder, we have a muscular layer that's called the detrusor muscle. This is going to be in the layer of the urinary bladder, because once we fill up with urine here, we're going to talk about kind of what happens afterwards. And then we have the exit of the urethra. So at one point when urine needs to be expelled, we're going to have contraction of the detrusor muscle. So it's going to squeeze and remove urine from the urinary bladder. The urethra has a thick kind of layering, mucosa layer, the inner, and kind of the next layer, lamina propria, because acid in the urine. So there is acidity. It's not as acidic as the stomach, but there is acid or urine is more acidic. So the pH is lower. So we need extra protection in the urethra in that area to protect from the lower pH, the acidic nature. So this is just looking at a better picture. So we have the ureters coming in. They actually come in down at the inferior part. All of this is going to be the detrusor muscle. So you can see kind of surrounding in the layer. And then we have the urethra here. So we also see rugae, because this is going to stretch out and then wrinkle when it's shrunken. And so this is going to be kind of the components of the urinary bladder. And we'll talk about the external urethral sphincter. Is going to be skeletal muscle. So this is where you're voluntary, where you can voluntarily urinate when you are ready. And then we also have an internal urethral sphincter, which is going to be in this area, right around the entrance of the urethra. That's going to be involuntary. So that's going to open. And then once you are ready to urinate, then the external urethral sphincter is going to open. So micturition reflex is going to coordinate the process of urination. It's going to be a local reflex, meaning it's going to go to the spinal cord, is going to mean the local reflex. And there's also a central pathway that's going to be processed by the cerebral cortex. So what happens with micturition? These events are going to all occur kind of simultaneously, meaning all at once. So you're going to have contraction of the detrusor by the autonomic nervous system. So this, again, the detrusor is a smooth muscle. You can't decide when it contracts. It's going to be the autonomic nervous system. It's automatic. Then you're going to have the opening of the internal urethral sphincter. So again, that smooth muscle, same thing. It's going to happen by the autonomic nervous system. If you are ready to urinate for micturition, then your somatic nervous system, so it's going to be voluntary and skeletal muscle, is going to open. So you have to squeeze the bladder with the detrusor, open one gate, the internal urethral sphincter, and then open the third gate and allow urine to flow. So what happens when your bladder shows that it's full, then you're going to get stretch receptors activated. So stretch receptors are going to feel the pressure of a large amount of urine in the bladder, and it's going to start the process of micturition. Micturition is part of the parasympathetic autonomic nervous system. So remember, it's going to be craniosacral section. So this is the sacral region of the spinal cord is going to be part of micturition. Parasympathetic, again, is our rest and digest. We don't care about urinating when we're running and fighting, but when we're resting and digesting, then we will be concerned with urination. So the parasympathetic neurons that's going to happen and come from the sacral region is going to cause contraction of the detrusor and opening of the internal urethral sphincter. What happens is actually inhibiting the somatic nervous system. So usually it is contracted. So that's what's holding it closed. So what happens is you relax that sphincter, it releases its pressure and opens that way. So you actually stop the stimulation of that muscle to allow it to relax. And that's why you inhibit the somatic pathways. So looking at pictures, so first you have the stretch receptors are seen because you have a full urinary bladder. You have fibers, afferent fibers going to the spinal cord, to the sacral spinal cord, and then coming out, you have parasympathetic fibers. Again, the parasympathetic is the long preganglionic and the short postganglionic. So we bring that command that the stretch receptors are being stimulated, and we come back and have the detrusor contract. That is going to increase the pressure of the urinary bladder, so then we're going to have to open our sphincters. So what also happens as well is with this kind of stretch receptor reflex, you're going to get also comprehension or go to the cerebral cortex. So what happens in this situation, so you have the reflex come, not only is the stimulation going to go back to the detrusor, but it's going to go up the spinal cord to the cerebral cortex as well. So that's going to be the central pathway. You're going to go central to the brain and also the local where it's going to go right back to the detrusor. So the sensation of the stretch goes to the thalamus. Then the thalamus is going to send that to the cerebral cortex saying your bladder is full, you need to urinate. Then your cerebral cortex is going to go, okay, it's convenient. So meaning you're in a restroom, then you can relax the external sphincter. So then the signal comes down all the way to relaxing voluntarily the external urethral sphincter. And that's going to also include relaxation of the internal urethral sphincter because the local pathway is already pushed that open because of relaxation and increasing pressure. So you're basically just kind of separating the internal urethral sphincter with pressure increase, and then you'll relax the external urethral sphincter. This is the prostate, so it's showing it's a male. So then we lead to urination. Some conditions when the kidneys aren't working appropriately, renal failure is one of them. So kidneys can't do their job. You can't get rid of wastes, and they can't help with all the homeostatic mechanisms that they do with ions. So you actually get a decrease in urine production because your kidneys aren't able to filter and make urine. You actually have a rise in blood pressure because you're not making the urine. So more volume in your blood means more blood pressure. Your kidneys are also involved in erythropoietin, a hormone. Remember, hormone that stimulates red blood cell production. So you get a decrease in red blood cells and causing anemia because this hormone, erythropoietin, is not released. And sometimes you can get sleeplessness, seizures. This is a lot of times not getting rid of the waste products, and ammonia building up can cause these issues. You can be delirious and eventually coma. Chronic renal failure kind of is the name that it's a long term. So it's slow. The kidney function goes down slowly. You can slow down that kind of deterioration, but you can't stop it or cure it, make it better. So it's always going to go and progress. It just, you can slow it down and have it take longer. So some things that are involved is actually restricting water and salt and protein. So this is going to put less strain on the kidneys because they're worried less about water volume and water volume with salt as well. Protein intake means there's less processing of amino acids, so there's less nitrogenous waste. So that's where the decreased protein intake comes in, is because the less waste you make, the less the kidneys have to deal with. So you have a lower volume of urine produced and less waste produced. You also get acidosis. Remember, acidosis is going to be a lower pH in the blood. And this isn't having to do with the respiratory system. This is because of the kidneys. Remember, the kidneys will secrete hydrogen ions if needed. And this is where you're not secreting it appropriately. So you're maintaining or keeping more hydrogen ions than you should. And that'll cause a decrease in pH in the blood. And you can take bicarbonate orally and help with buffering that pH. Acute renal failure is in the name, where it happens all of a sudden. So kidney functions fine, and a few days it's really, really bad. So it's sudden. So it can either be a sudden slowing down or stopping of your filtration by your kidneys. So it can be multiple different ways. This is life-threatening. So it's not like your body with chronic and it's slowly getting worse. Your body can adjust pretty well until it's so bad it can't anymore. Acute renal failure being fine and then all of a sudden, boop, done. That's when it's life-threatening and you need treatment. So some toxins can attack the kidneys and cause acute renal failure. Ischemia is going to be lack of oxygen, so for many different reasons. Remember, a lot of oxygen, 20 to 25% of your oxygen at resting is going to be going to the kidneys. It's very sensitive to losing its oxygen. Urinary obstruction, so if for whatever reason you can't urinate, everything gets backed up. So you're going to cause issues with the kidneys. So if you can't urinate, you can't empty your urinary bladder. Your ureters can't bring more urine into your urinary bladder. So it's going to get backed up into the kidneys and cause damage. Trauma, so damage to the actual kidneys can cause damage to your nephrons, and that's significant trauma, and also allergic reactions. You can recover from this, and you can get function to be back to normal if you survive. Again, it's life-threatening, but if you get through the kind of worst of it, you can recover either complete function or most of your function. So it is something that can be reversed if, again, you survive the first part of it. So it is very serious condition and have to be treated quickly and aggressively. So we look at dialysis. If you've heard that, that's going to be basically becoming a fake kidney. So what happens is you use the diffusion, you act like a filtration membrane is the dialysis membrane. So the same thing that would happen in the glomerulus and the glomerular filtration membrane is going to happen here. So solutes are going to leave the blood and go into dialysis fluid. You can adjust the fluid so you can have this occur. So uses that membrane to pretend to be a glomerulus. And so you can kind of falsely control and falsely be a kidney and regulate the composition of the blood by regulating what's in the dialysis fluid. So we can have still the same thing that we saw. You have the membrane doesn't allow plasma proteins or cells to leave, but it's going to allow ions, nutrients, and organic waste to leave. So we're still having the same process of a kidney, it's just a fake one. So dialysis is going to help with the symptoms of renal failure, so you don't have the waste buildup. You can manage your ion and your water balance, but it's not a cure. The only cure for renal failure or kidney failure is a transplant. And this is severe. You have to be on a transplant list, and it can take years to get there. And it's pretty good. You can have one functioning kidney, so patient survival is actually more than 90% 2 years after transplant. We like having a close relative because that can decrease the rejection. So you can get closer to matching all of the kind of remember on the immune system is recognizing foreign material, so it can be closest to your actual individual MHC, the membrane or major histocompatibility complexes. So it can be closer matches to those, so there's less risk of rejection and less risk of your immune system attacking the new kidney and killing it that way. So you do have to do immunosuppressive drugs because no matter what, it's not going to be the same as what your kidney is, but it can be close and reduce that. Kidney stones, if you get to a point where concentration of solutes is too high, that solute can actually come out of solution or precipitate and smush together to become crystallized or stones. If the stone gets large enough, then it can cause issues. So again, if it's forming usually in the renal pelvis, right where the exit of the ureter is, if we get to the point where it can block a ureter, then it's going to cause obstruction and cause issues that way, and that's where the pain and everything. So too much solutes comes out of solution, gets into little grits and stones and crystallizes. So these are just kind of different types. You don't need to memorize the types or the occurrence. I'm just showing you different types. A lot of them are calcium based, calcium oxalates, monohydrates or dihydrates, uric acid, another calcium phosphate, magnesium. So these are all solutes, calcium, cysteine, xanthine. Sometimes we can look at electrolyte imbalance with issues with the kidneys as well. Hyponatremia is going to be low sodium levels. So that's below our reference range. Oftentimes it's because we're taking in too much water, and sometimes it's not enough salt, but usually our diet has enough salt. But also cirrhosis of the liver, so scarring of the liver. Congestive heart failure can cause it, a large amount of swelling or edema, and our friend, the kidney failure. So you can see a lot of different kind of generalized signs. That's why we do blood work a lot of times. So this will be on chemistry. We'll look at your sodium levels. So you go to the doctor, you're really not feeling well, they're going to do blood work and look at this. So you can get kind of upset GI, nausea, vomiting, headache, even to the point where it's confusion, sleepy, fatigue, not hungry, muscle weakness, spasm, cramps, seizures. If it's severe enough, it can be a coma. So it's kind of generalized kind of symptoms because you have kind of too much water, not enough sodium for things like action potentials and things like that. So that's why we look at sodium levels. Opposite, hypernatremia, too high of salt levels. Oftentimes this is dehydration, not enough water, urinating too much and not drinking enough water, sweating too much, losing too much water um in your intestines, diarrhea. So you're having too much sodium concentration because you have less water. Same thing that we see. You can see a lot of similarities. So you have lethargy, weakness, irritability, neuromuscular excitability. This again is the involvement of sodium in action potentials, and swelling. Because again, water follows sodium. Yeah, it's severe enough, again, seizures and coma. You can also have hypokalemia, which is loss of potassium. So hypo is low, kalemia has to do with potassium. Is either not eating enough, severe diarrhea, sweating too much, and other diseases. So mild hypokalemia, mild low potassium can actually lead to increase in blood pressure. Moderate hypokalemia gets to muscular weakness because again, we're messing with action potentials. Kind of pain in the muscles and muscle cramps. And severe hypokalemia is actually flaccid paralysis. So it's going to be where your muscles don't work at all. And that can lead to what's a big muscle? Your diaphragm. So that can actually affect your breathing because it's going to cause issues with the contraction of the diaphragm. Hyperkalemia is too much potassium. That's another issue with the kidneys. You can also see it with medications, diseases, too much potassium if you're eating a box of bananas every day, and also box jellyfish venom is going to cause this. Again, it's not exact. You can have just not feeling well, palpitations in the heart, muscle weakness again, and then we even can get to the point where we get an arrhythmia or cardiac arrest. So it is messing again with muscle contraction and action potentials. So you can mess up the muscle of the heart. So we do use, in some things, lethal injection can induce hyperkalemia, which causes arrhythmia that causes cardiac arrest. So giving potassium chloride IV can cause death. And that's how sometimes it's done. So it's just kind of morbid fact.